Welcome all to the today's session. So today we will be completing our early pregnancy module and the remaining topics, especially mainly the TOG articles are pending. And also we will cover one of the important GTG, that is recurrent miscarriage. Okay. So we start with today's session with our tagline, that is Master MRCOG with concept oriented clarity. So this is the first talk which we will be discussing, that is the role of ultrasonography in the diagnosis and management of early pregnancy complications. Okay, so what is the role of ultrasonography in the management of early pregnancy? Okay, so early pregnancy complications are very common, and most of these complications happen between 11 and 8 to 11 weeks of gestation. So remember this, if by any chance if the SBA comes, generally the SBA may come from your talk article also. Doctor, if you can keep your mic off, it will be better. Okay, these complications generally happen between 8 and 11 weeks of gestation. Okay, now once we discuss about the ultrasonography in the first trimester, whether it is transabdominal or transvaginal. So it is always the transvaginal which is standard and essential tool for the assessment. Most scans provide a clear diagnosis, but some may not be always diagnostic. Okay, so there are two important terminology as far as early pregnancy scans are concerned, that is expected from RCOG and MRCOG candidates. Two concepts. That is, one is a concept of pregnancy of uncertain viability, that is PUV, and second is a pregnancy of unknown location. Okay, so what is the pregnancy of unknown viability? So when you can see intrauterine gestational sac, but viability is not clear, we call it as a pregnancy of unknown viability. Okay, second concept is a pregnancy of unknown location. Now here you are not able to visualize the pregnancy inside or outside the sac. Okay, that means there may be beta hCG positive, there will be history of amenorrhea, but on the scan you are not able to visualize the pregnancy either inside or outside the uterus. Okay, so this condition is a pregnancy of unknown location, and generally one SBA in your first 10 questions will be about either pregnancy of unknown viability or pregnancy of unknown location. Okay, so pregnancy of unknown viability and unknown locations are not diagnosis, but they represent the current status of investigation. Okay, so in such cases, what you need to do, second opinions and repeat scans should be part of standard practice before diagnosing the miscarriage. So when you are giving the diagnosis of miscarriage, especially the complete miscarriage, so always keep in mind these particular things. Okay, especially the pregnancy of unknown location. Okay, so miscarriage diagnosis preferably not to be given in the first scan. Always take a second opinion and repeat scan. So this concept also generally they test in the SBS. Okay, so caution is essential before treating suspected ectopic pregnancy with methotrexate to avoid harming a possible intrauterine pregnancy. So when you are thinking about ectopic pregnancy, always keep the heterotopic pregnancy in mind. Okay, so ultrasound and serum markers, generally we use SCG. Okay, have greatly improved early pregnancy management. However, use or misinterpretation of these tests can lead to serious harm. In a hemodynamically stable woman, it is generally safe to wait until a definitive diagnosis is made. So when you are in doubt and patient is clinically stable, you go for conservative management, especially with the beta hCG monitoring. Okay, now we'll see about the pregnancy of unknown location. Okay, so pregnancy of unknown location is not a diagnosis, but it's a temporary classification until a definitive diagnosis is reached. Now, what is the importance of pregnancy of unknown location? Because almost 30% of these pregnancies, that is 7 to 30% of these pregnancies may be an ectopic pregnancy. They will be either evolving ectopic pregnancy, they may be failing pregnancy, or there may be evolving intrauterine pregnancies also. So there is almost 1/3, so 7 to 30% chance that they might be evolving ectopic pregnancy. Okay, depending upon the quality of ultrasound and patient population. Okay, so management of pregnancy of unknown location. Basically, these pregnancies are of two types. One is a low risk pregnancies, and another is a high risk. High risk. Okay, so what we mean by the low risk? Low risk, we mean to say that this pregnancy will either fail or they will become the intrauterine pregnancy. That means the patient herself is in a low risk category, because even if the pregnancy is failing, there is no risk to the patient as such. And if the pregnancy is becoming intrauterine, then also there is no risk to the patient. Okay, but if it is going to be evolving an ectopic pregnancy, she is going to be high risk. So we need to categorize these patients into either whether our patient is a low risk or whether the patient is high risk, and that will be on the beta HCG levels. Okay, generally these two hormones, the serum progesterone and beta HCG, but progesterone is not useful from that particular point because it has got limitations. It misclassifies the viable intrauterine pregnancy as a high risk pregnancy, and even ectopics are classified as a low risk pregnancy. So serum progesterone is not useful. What we use is the serum SCG and SCG ratio. That means immediate current beta SCG and 48 hours prior the SCG level, or we do the SCG at baseline and repeat the beta SCG after 48 hours and we take the ratio. Okay, so that ratio is helpful in dividing this pregnancy as a low risk or a high risk, and that model is called as M4 model, that is multinomial logistic regression. So this M4 model, there is a one flow chart which we should see. Okay, now basically why from examination point of view, because they'll give you the scenario and they will give you the beta SCG values, they will give you the 48-hour beta SCG value and the initial beta SCG value. Either it will be increasing or it will be decreasing. So we need to calculate this particular ratio and find out in which where exactly in this particular table it fits. Okay, and accordingly the option will be either repeat UPT in 2 weeks, or repeat TVS in 7 days, repeat TVS in 10 days. So they'll give you many options and we will get confused what exactly is to be done. There will be very close options, whether we should know whether it is to be monitored by beta SCG or whether it is to be monitored by TVS and after how many days. This is very fixed. Okay, so basically we have just mentioned that we have two things. One is a low risk and another is a high risk. Now what is low risk follow-up and what is high risk follow-up? If your patient is going to be low risk follow-up, your management is a simple: you repeat UPT in 2 weeks or repeat scan in 1 week. So either of these two you are going to select. That means your beta HCG is either increasing appropriately so that it will be an intrauterine pregnancy, or your beta HCG is decreasing appropriately. That means it is going to be a failed pregnancy. So if it is going to be a failure of the pregnancy, repeat UPT in 2 weeks. And if it is going to be an intrauterine pregnancy, repeat scan in 1 week. So either of these, only you have to think of these options if it is going to be low risk. Now, high risk pregnancy, that means this particular patient is likely to develop ectopic, is likely to develop. So this patient requires frequent SCG monitoring and ultrasound scans. So what does this M4 model tells? Okay, now this M4 model, see, look at the whether the beta HCG is increasing or whether the beta HCG is decreasing. So increase should be adequate or the decrease should be adequate. Okay, now if the beta HCG is increasing and it is more than 66% is rise, that means it is going to develop into the intrauterine pregnancy. Now if it is going to decrease and decrease is satisfactory, that means it is decreasing by more than 13%, more than 13% decrease. That is also satisfactory. That means it is going to develop into the failed intrauterine pregnancy. Okay, the patient will not have the risk. So if it is going to become a failed intrauterine pregnancy, failed pregnancy, then you will repeat the UPT in 2 weeks. Okay, but at the end of 2 weeks, if the UPT is positive, then you will do the SCG. Okay, so if the beta HCG is decreasing adequately, that means more than 13%, you repeat UPT in 2 weeks. Okay, because it is a low risk. Okay, now if it is increasing and increasing adequately, then it is likely to be a normal intrauterine pregnancy. You will repeat a TVS on day 7. Currently you are not able to visualize. Currently it is a PUL, that is pregnancy of unknown location status, but after 7 days we will expect something if it is a adequate intrauterine rise. Okay, so next step, SBA, you should not miss this particular type of SBA. Now the problem is with the high risk. Okay, now high risk means it is likely to be an ectopic. That is possible when your increase is not adequate or whether your decrease is not adequate. Now increase is less than 66%, that is going to be a probable ectopic pregnancy. So what we will do, you will repeat TVS on 7 days, or if you're at a time when your beta HCG is expected to be more than 1000. So when your beta HCG is increasing either adequately or inadequately, you have an option of repeat TVS on 7 days. Okay. So if it is increasing adequately or if it is inadequately increasing, you go for TVS on day 7. Okay, this is the option you will select. These are certain things which you will remember. Now, if it is decreasing, but the decrease is not adequate, that means either it can be a failed pregnancy of unknown location or it may become an possible ectopic. So this case, you will monitor by SCG. So repeat SCG on day 7. Okay, so here you have to repeat SCG on day 7. Here it was repeat UPT on 2 weeks and other repeat TVS on day 7. I hope this you have understood the M4 model. There will always be one SBA on this type of question. Okay, that is why I have given adequate time for this on this slide. Okay, thank you. We'll go ahead.
That means the last one which you were telling, when the decrease is not adequate, and then how to monitor.
So what the guideline says that you repeat these patients. Here it is assumed that the patient is hemodynamically stable. Okay, and we expect that the beta SH is decreasing. Okay, so patient is hemodynamically stable. Only thing is that we do not know whether it is a failed pregnancy of unknown location or a possible ectopic pregnancy. Okay, so here you are going to monitor this patient. If it is going to decrease, decreasing level, then definitely it is going to be low risk. By any chance, if you are getting some rise somewhere, then you have to think of other causes. Are you getting it? But if it is a decreasing trend, the what the guidelines says, repeat beta SCG on day 7. From the SBA point of view, this particular table we should remember. Okay. Another thing, depending upon the hemodynamic stability of the patient, if the patient is hemodynamically stable and having a pain, in that particular case, we have the two options. One, monitoring with serum beta HCG, and we will consider laparoscopy. Okay, so patient is stable, serum HCG becomes the first, and we may consider laparoscopy in this particular case. Okay, if the patient is hemodynamically unstable and having pain, then definitely surgical option, that is laparoscopy or laparotomy. And patient is hemodynamically stable and patient is absolutely pain free, then it is an expectant management with beta SCG ratio, that you will do SCG at 0 hours, repeat SCG at 48 hours. Okay, and then we will interpret as we have already seen the M4 model. Okay, now coming to the yeah. Now, again, we are still there in the ultrasound in the first trimester. So what we have seen is the pregnancy of unknown location first. Okay. There it comes the role of ultrasound when you are going to repeat either on day 7, TVS on day 7, whether it is increasing adequately or whether it is decreasing, whether it is increasing adequately or increasing inadequately. You go for TVS on day 7. Now you are able to see the ectopic pregnancy. Last time we have gone into the details of ectopic. So ultrasound pictures, we may not go into the too much of details here. Okay, because it is a repetition. So ectopic pregnancy is implantation outside the endometrial cavity, commonly in the fallopian tube. It is potentially life-threatening. Risk factors are smoking, PID, previous ectopic, ART treatment, and previous tubal surgery. And more than 50% of women with ectopic pregnancy have no identifiable risk factors. Okay, so this is as per the TOG, more than 50% women do not have the identifiable risk factors. Okay, now coming to the diagnosis. So TVS, that is transvaginal ultrasound, is the gold standard. So diagnosis in first presentation, more than 70% will be diagnosed and around 90% will be diagnosed in a subsequent scan. Okay, so ultrasound signs of the tubal ectopic along with the GTG, we have gone into the too much of details. But what the talk mentions, you will see a extrauterine GSAC with YOSAC, which may or may not have the cardiac activity. So it will be either viable if it is a cardiac activity or non-viable without cardiac activity, tubal ectopic. Then there are two signs. One is a Bagel sign and second is a blob sign. Okay, so Bagel sign is an adnexal mass with hyperechoic ring, while blob sign is a homogeneous mass which is separate from the ovary. Okay, so ectopic pregnancies not visualized initially are classified as a pregnancy of unknown location, often due to they are too early or they are so small. Okay, And ultrasound accuracy in experts hand is specificity is around more than 99%. Okay, so nowadays with better good ultrasound machines, the specificity is good. Now here you see this blob sign. Okay, so this is the adnexal mass which they have shown. So transvaginal ultrasound showing a tubal ectopic pregnancy. The majority of the tubal ectopic pregnancies are visualized as a masses or a blob sign. Okay, so as per the talk, they have mentioned majority of the tubal pregnancies are visualized as a homogeneous masses or blobs. Okay. Now coming to the management approach, as per the NICE guideline 2012, the first line of management is a methotrexate management. However, caution before use, exclude viable intrauterine pregnancy to avoid serious fetal abnormalities, and errors in methotrexate use are the major concerns, especially in the US. Now, for medical management, we have already seen properly the patient should be clinically stable. Wait for 48 hours to assess SCG ratio to confirm the diagnosis before the treatment. And SCG ratio will also help to select the women for expectant or medical management. Sometimes, expectant is also work, especially in 1 out of 3 cases. Okay. So expectant management criteria, ectopic mass should be less than 30 millimeter. There should not be any embryonic activity, and beta HCG should be less than 1500. Okay. NICE guidelines is less than 1000. Okay, but up to 1500 we can consider it. Okay, and about 1 in 3 in such cases may be successfully managed by the expectant management. This also you should remember from SBA point of view. Almost 30% of these ectopics can be managed with by the expectant management. Okay, provided the criteria are fulfilled. Then non-tubal ectopic pregnancies. Now, non-tubal ectopic pregnancies are less common but cause disproportionate morbidity. Okay, they are often late and are harder to diagnose. And these are interstitial, cervical, cesarean scar, heterotopic, cornual, ovarian, abdominal pregnancy. And these last time we have discussed their ultrasound features. Okay, now interstitial ectopic incidence is around 1 to 6%. Here the implantation is in the interstitial part of the fallopian tube. 6% maximum, 1 to 6% is the incidence. Here the ultrasound peculiarity is the interstitial line sign, that is a ecogenic line connecting with the endometrial cavity, connecting endometrial cavity to the sac. Okay, sensitivity is 80%. It presents later with strong with higher SCG levels, and 3D ultrasound helps to visualize connection between the cavity and the sac very clearly. Okay, so there is a role of 3D ultrasound, especially in a interstitial type of ectopic pregnancy. Again, from SBA point of view, you remember if they ask. Okay, so this is a 3D ultrasound picture. This is the uterine cavity which you can see, and here the interstitial portion is enlarged. So this is an interstitial type of pregnancy. So this is a three-dimensional image showing. So it is a three-dimensional image showing the coronal view of the uterus with right-sided interstitial ectopic pregnancy. The ectopic pregnancy was successfully treated with a single dose of IM methotrexate. Now, interstitial here in ectopic, we should know the type of ectopic and the preferred management, whether it is a medical or surgical. Last time we have gone into too much details of that. Okay. Now, this particular chart also I have gone through. Actually, it is not from our RCOG guideline, but just for the sake of completion, I have mentioned that is the timing of rupture. If you see the timing of the rupture, especially the interstitial and the cervical and abdominal, these are the 3 pregnancies which will rupture late. Okay, while most of the pregnancies will rupture around 6 to 8 weeks of, that is ampullary, ischemic, femoral will rupture by around 6 to 8 weeks, but tubal, which is interstitial in nature, may be between 8 to 16 weeks, that is often around 12 weeks of gestation. So larger gestation this can take. Same thing is around cervical also. It is variable, often late more than 12 weeks. Okay, ovarian also around 6 to 8 weeks, and abdominal can go even into the 3rd trimester also. Okay, so that is the timing of the rupture. In case if they ask, you should know. Okay. Now, cervical ectopic pregnancy criteria, we have seen it, there will be empty uterus, barrel-shaped cervix, cervical G-sac will be below the level of the internal os, and the sliding style will be negative, peritropoblastic blood flow on the color Doppler. Okay. So, caesarean scar pregnancy. Okay. Now, this UK early pregnancy surveillance service, that is UK EPSS, established to track and study such cases. So as per this UK EPSS, there are diagnostic criteria. Gestational sac should be outside the uterine cavity, implantation into previous scar or within the myometrial mantle, and sustained peritropoblastic flow on color Doppler. Okay, so these are the criteria which should be satisfied for the cesarean scar pregnancy. After this, we will have a separate talk discussion for the cesarean scar pregnancy. Okay, so needs to be distinguished from the miscarriage. Again, here the sliding sign will help. So any differentiation, this sliding sign will help when you are differentiating from miscarriage. Okay, should be managed in a specialized center due to diagnostic challenge, and diagnostic criteria is not yet validated. Second is a heterotopic pregnancy, that is simultaneous intrauterine and ectopic pregnancy, intrauterine and ectopic pregnancy, common with assisted reproduction, often misdiagnosed as a singleton or twin intrauterine pregnancy. Okay, so key point is the presence of intrauterine pregnancy does not exclude ectopic, especially in ART patient. Okay, so even if you see intrauterine, but that will not exclude the heterotopic pregnancy. And there are two pregnancies which we have discussed last time, in which beta SCG monitoring may not be appropriate. Like one is a heterotopic pregnancy and another was an intra-abdominal pregnancy. I hope last time you remember this, we have discussed here beta SCG rise may be adequate. Okay, because you
Yes.
have a developing intrauterine pregnancy. Okay.
Yes.
Okay, so that finishes our first topic of role of ultrasound in the uh, first trimester. Okay, thank you.